everyone. I'm Bojo from the First Hospital of China Medical University. The case I share today is the hypoglycemia mystery. Hypoglycemia is a group of symptoms caused by a low concentration of plasma glucose, showing sympathetic excitation and sugar deficiency in brain cells. Symptoms of hypoglycemia: plasma glucose is less than 3.0 micromole per liter, and the symptoms can be reversed after eating meals. Clinicians call them the Whipple's trails, which can be used for diagnosis of hypoglycemia. This case is a rare special case of a patient who looks like hypoglycemia but cannot follow the conventional clinical diagnostic rules. The story started from a complaint from an endocrinologist saying that a patient was hospitalized for years of repeated hypoglycemia, but when glucose was low, the patient had no obvious symptoms, but there were obvious differences between the results of venous glucose and the peripherals, questioning the accuracy of the glucose testing. After reviewing the records and data, we first exclude the possibility of inaccurate testing. However, we attach a great importance to the satisfaction of clinicians. So we got in touch with the clinician to analyze the root cause of the problem. The patient is a 50-year-old female, got no obvious cause of dizziness, headache, and hunger since 5 years ago, which can be relieved after rest and eating. Half a month ago, the above symptoms worsened. The glucose results were between 1.8 to 2.2 micromole per liter. Meanwhile, the routine physical examination were normal. We can find the Whipple trail here, so the patient was initially diagnosed as hypoglycemia. The common causes of hypoglycemia are listed here. We tried different blood testings and physical examinations to help confirming the real cause. Most of these possibilities were excluded, except the endogenous hyperinsulinemia. Here are the criteria for confirming this. The laboratory findings of insulin secretion met this diagnostic criteria. We learned about that there are 5 main causes of endogenous hyperinsulinemia. According to the medical history of this patient, there are only 2 possibilities left. Further, the prolonged OGTT testing showed that the patient has an abnormal glucose tolerance, and the result of glucose 0.35 caught our attention, because the patient never showed symptoms even this low. The hunger test did not show the typical result, so the diagnosis of insulinoma still cannot be made. With the questions, our lab did a series of investigations. No obvious affections could be found until we found an article saying that excess of white blood cell or red blood cell can cause excessive glycolysis in vitro and cause false hypoglycemia. Wait, what did we miss? The patient's white blood cell, red blood cell, and platelets were significantly increased ever since she went to hospital. No inflammations, fever, and other related clinical manifestations. At this point, we could infer that it was a false hypoglycemia caused by an abnormal increasing of blood cells, and we gave the advice to transfer this patient to a hematology department for further treatment. This case was a good reminder that clinicians should pay attention to the clinical consistency of patients' symptoms and test results, and the case also played a demonstration role for the cooperation between the laboratory and the clinical practice. Thank you very much.